Is the sixth and final webinar of the first webinar series here at Find a Cure. My name's Libby and I'm the Fundraising and Communications Officer here. Today's webinar is going to be on developing medical guidelines for our conditions, the aim of which is to raise awareness of a particular condition among healthcare professionals. And this is important particularly for rare diseases because they're so uncommon and many health professionals won't have come across them before. We'll be hearing from two really great speakers, both of whom are on this agenda here. First up, we have Carol Ossai from Sickle Cell and Young Stroke Survivors, aka SCYSS. She's going to be talking about how to ensure lay representation when developing clinical guidelines. Following her, we'll be hearing from Julie Valortigara from Ataxia UK on how to update and disseminate medical guidelines. Both those presentations will last for half an hour, and then we'll be having half an hour for questions and answers at the end. To ask a question, all you have to do is type it into the question box in the control panel. I will receive the question after you submit it, and I'll ask it to the speakers either directly after their talk or in the Q&A session at the end, depending on the time available. As you're listening along, please do be thinking about anything extra you'd like to know for your patient group, no matter how silly you think it might be. We really do want you to come away with a good understanding of the topic in hand, and this is a great opportunity for you to learn more from some very experienced speakers. The webinar will be recorded, so don't worry if you don't catch everything. You can also tweet about the webinar using the hashtag #explainedwebinar. Cool. So first up, we'll be hearing from Carol Ossai, founder of Sickle Cell and Young Stroke Survivors. She's the founder and chief executive, and she founded it 12 years ago after her son Daniel, who is now 20, was born with the rare genetic blood condition sickle cell anemia. This condition causes organ damage and excruciating pain in children and leads to death in early adulthood. After her son's first stroke at the age of 6, Carol realised there was very little support for her and her child, and she wanted to make the information she sourced from doctors' conferences and the internet available to other families, so she set up SCYSS. So with that, I will pass on to Carol. Thank you very much, Carol.
I'm going to talk about my experience as a layperson on how we get involved in patient engagement and involvement. I think it's very important, especially from my experience and my background, to ensure that we are represented as a rare disease and also very size condition. Sickle cell doesn't really get enough attention as it's supposed to be, especially as it's one of the most genetically predisposed conditions in Afro-Caribbeans. I'm going to talk about mainly how we've kind of helped to ensure that the childhood guidelines on childhood stroke have been recently launched and the process leading up to that. So I got involved with the stroke side of things after my son Daniel, who's now 20, had a stroke at the age of 6. So after his stroke at the age of 6, it was a really trying time because he not just had one stroke, but he had several others. So I decided to make sure that sickle cell stroke induced was something that people knew about, and especially mothers like me, so that we're not shocked when it does happen. At the time when he had his stroke, I spoke to the Stroke Association, who told me that they don't cover childhood stroke. So basically I had to start looking for information myself on how to deal with paralysis, and he had also had another rare condition called moya moya, which basically was explained to me as having extensive narrowing in the blood vessels in his brain. So that was causing a lot of TIAs. But he's now a young man, as you can see in the picture, and he's now in university, going into his 3rd year. But it was difficult trying to make sure that, you know, a lot of the disabilities that stroke causes in children is, you know, was not that pronounced. So he had a lot of physiotherapy, and in that stroke journey I got to meet a lot of people, a lot of clinicians, and I was just like a sieve, you know, gathering information, learning what to do, what not to do. And at the same time, the nurses started referring people to me, and I thought, oh wow, this information is crucial for other parents, so I need to start sharing. So Sickle Cell and Young Stroke Survivors was started as a support group first, and then after that we became a registered charity as our needs grew. Lay representation needed. It's very important that people, you know, in the medical field get to hear the experiences of, you know, the experiences of people who go through the illness. Many a time we see clinicians who maybe they're experts in their field because they studied it, not because they live with it, or not because they have a child who lives with it. You can only gather the experience of parents by actually asking them. You can only gather the experience of children and young people by asking them. All that knowledge put together is what I understand to help to build people's career in the medical field. It builds on research. It looks at gaps in illnesses and how we can best look after the patient's needs. The carers are involved. They have their own experience. The patients have their own experience. And it's good that everyone joins together to make sure that the experience that is gained is put into what I call a cooking pot, melted, put into a cooking pot, and the product that comes out of it is something that will benefit everybody. Before, this is what the childhood's clinical guidelines looked like. This was, as you can see, developed in October 2004. So from 2004 to May 2017, this is what we had to refer to. And when you look at the guidelines, as it were, at the time, first of all, it didn't cover hemorrhagic stroke. It only covered ischemic stroke. Secondly, there was a lot of recommendations that were made inside but not actually practiced outside. So because of that, we had a disjointed service. The service you get from one hospital is not the same that you would get from another. For instance, I remember when my son had his first stroke, we went to King's, which they knew about sickle cell and childhood stroke, so the services was okay. But when he fell ill and he went to Guildford, there wasn't any guidelines or care pathway for childhood stroke, so they were actually at a loss as to what exactly should we be doing. So they were asking me as the parent, what is normally done? You know, they were asking Daniel, who was in intense pain, what do they normally do for you? And I even remember speaking to a GP, his GP at one point, and he said, well, we don't know the boy, take him to the hospital. So that was what was in place for us, you know. It was the unknown. You don't know what you're going to get depending on which hospital or which clinician you see. We all live in hope, and going into the process of ensuring that no other child has to suffer the way that my child did, and no other carer should also suffer the, you know, the lack of information and lack of support that I did. So my hope going into the guidelines was, first of all, I just knew that there were so many misdiagnoses of childhood stroke taking place in hospitals. Because of that, we even had 2 children that died from the charity. So it was important that we try to prevent the strokes, and there's a 90% risk that any child that has a stroke will also have a further stroke. So it was important that we had the medics involved to make sure that there was a consistent procedure, a consistent care pathway in all hospitals. And that could only be done through having one childhood stroke guideline that would take people through the process, right down to the paramedics that you call straight away, for them to understand. If you say to them, your child's had a stroke, they know exactly what to do. But it was also important that parents were involved in this to make sure that, you know, their voices are heard, because there's a lot of emotional trauma that parents go through, not knowing what to do, seeing your child paralyzed, and you know, it's just so difficult. It's a difficult time. So I went in it with the hope of making sure that all these things were covered. This is what we came out with. In May this year, 2017, the Stroke in Childhood Guidelines were launched. But the important thing with that was that I ensured that hemorrhagic stroke was part of this, because it wasn't part of the old guidelines. So it looked like we were updating the old guidelines of 2004, but in actual fact, we actually rewrote the whole guidelines. It took a big team of clinicians from all over the country to come together. The Royal College of Pediatrics and Child Health, they spearheaded it. The Stroke Association, they funded it. And it involved a lot of parents, and it was a big team. And I was happy to be part of that team. There were three expert parents, as we were called, on the guidelines. And the first thing that we asked for is that, apart from the clinical guidelines that mainly clinicians would see, we would like to have our own guidelines so that we know exactly what is happening at each stage. And we came up with this version, a booklet for parents that is a nice A5 size to fit in the handbag, and it gives in information about what is happening. It gives information about the different types of stroke. It gives that information that parents would read and feel that they're now in the know, that they now understand what is happening at that critical point when questions are being asked. So the booklet was something that I was really happy to see. Right now, it's being distributed all over England, and there's not enough hard copies like we would like to, but it's now in effect, is in existence, and it's a tool for every parent that is going through this to actually have as a comfort to them. So when I look at the journey in developing the guidelines, like I said, it was a big team. We had physicians, stroke physicians, adult stroke physicians, because we also had to learn from the adult services. The first guidelines was actually developed by the Royal College of Adult Physicians. So we wanted them to, from their experience, to actually contribute to this one, and it was very essential that they did. Personally, I didn't know what I was going in for, really. I basically thought that it would be get the old guidelines, read through it, update it, most of the recommendations that were in there, turn them into to-dos or something like that. So I didn't really understand the process that was involved. I didn't know what to expect. I wasn't sure what I should say and what I shouldn't say. And also, as I was representing a lot of other parents out there, I was kind of scared that I might forget a case that was important, or an experience a parent had told me, or a question that I had been asked. But through training and support from the team, we worked as a team. Nobody was looked at as, oh, you're not a doctor, you're not a person that has the know medical wise and things, but everybody was treated equally. And we parents were very, very supported. We were trained on certain aspects. A couple of us even bought ourselves medical dictionaries, but in the end we found that we didn't even need it because everything was explained to us so that we understood everything. And at the end of the day, it made it easier for us to actually say, hey, there's no stupid question or any stupid experience that we've been through, that everything actually, every little minute bit of our stroke journey needs to actually come out. And it was good because we also made friends with other medics, and we were able to even ask personal questions in terms of our own children and the experiences that and difficulties that they were having. So, like I said, it is important that parents are involved in the process. Sickle cell and young stroke survivors were involved in a lot of in 3 major PPI in research that is being undertaken by several universities. So that shows the strength that parents have in being able to represent a condition and talk about it, and involving patients and carers. It makes it real and it makes it relevant and to the professionals, and it sheds light on what is not just what is on offer, but what is actually needed, where the gaps are, what services are not reaching people in various areas or in different hospitals. So it's important that parents are involved and the patients too. Even if they're children have a voice too. Young people, they have a voice. They're the ones at the receiving end. They're the ones that end up in hospital in pain. So it's important that everyone is on board. And it's also important that clinicians are able to seek the voices of parents in case they're not involved, seek the voice of children, to ensure that everything that the experiences that they go through, that they're able to capture any gaps in services and any support that needs to be put in place. So, as I mentioned, our participation was quite robust, and like I said, I wasn't sure what what my input would be, but with training and support, I was able to feel relaxed and to, open up myself, because sometimes we go through things and we keep them inside and saying to ourselves, well, nobody's not going to understand what we're talking about. But this was a platform where we were able to talk and to also get that support that we needed. It did take a lot of time. This is work that happened over 2 years. So it wasn't the go in, update the guidelines and come out. No, it took more energy and time, and it took commitment. The important thing is to be committed. When you're doing these things, you need to be committed, and you also have, for instance, the conference call if you can't make it to a meeting. But we parents found that we wanted to be there face to face. The conference meeting, it didn't feel right. It felt that the expressions we had on our faces when we were talking was actually very important, because when you see the interaction and how people look at you like, wow, you're saying something very important, and you're thinking, oh, I'm just going to say it. But you know, when that interaction is there, you can see that, you know, you are important and what you have to say is important. So it took a lot of commitment, and which I was happy to do. The meetings, we had 10 meetings, but it was a bit more because we were also part of the childhood advisory group. So basically the meetings were double that. So this is just with the Royal College of Pediatrics, but we had meetings with the Stroke Association because the advisory meetings actually fed into the guidelines as well. We had to do review research papers. I have not done that before, so it was something actually very new to me. And we were given 1,500 literature to go through, and we were screaming, but at the end of the day, we looked at it and we thought, oh, this is actually good, because reading some of the papers and going through them gave us more experience, and going through that, we also saw from other countries what they had in place or what they did not have in place. So it was important to go through that, and it was quite insightful to learn a lot of other things to do with childhood stroke. So also we had to review emails. So we got emails with loads and loads of attachments to them. So we had to make sure we opened them, went through them, gave our feedback. And I was also representing a range of parents, you know, so it wasn't just, not just a range of parents, but, you know, also a range of childhood stroke. So hemorrhagic, which my son had, and also ischemic, which my son had. So that's why it was important that, to me, that hemorrhagic was not missed out this time. So we also had focus groups. So we had parents from all over the country. We had 2 focus groups. One was on ischemic stroke, and the other one was on hemorrhagic stroke. The hemorrhagic stroke was something that hadn't been done before. The Stroke Association hadn't actually listened to parents with hemorrhagic stroke. And on the day that we had that meeting, after the meeting, we all sat down in absolute silence because we were a bit stunned with what we actually heard, and to know that these parents, there was about 15 of them, had been living their lives in isolation and not really knowing what to do or what the outcome for them and their children would be. So it was really an eye-opener to be able to get that input. And at the end of the day, if we hadn't made sure that hemorrhagic stroke was included, we wouldn't have ever heard those voices. So that really did make an impact on the way that the guidelines changed. So from the experience of someone who leads the Sickle Cell and Young Stroke Survivors group, for me it was good to work with many clinicians. I gained a lot of personal knowledge, learned a lot, especially the literature review. To me, saving lives was important, especially as 2 close kids died, and one of them died from a brain hemorrhage, and I was kind of followed the process, the admission step by step, and from the time the mother called me till the time the child was taken to the hospital, and right up till she died, I was basically on the end of the phone. So it was about me reliving my experience, but unfortunately in this case, the child died. So, and it's also about, you know, for me to educate people about these experiences, and to feel that I have something to offer. And at the same time, as I'm educating people about it, educating parents on the signs to watch out for childhood stroke, then at the same time it reduces the misdiagnosis, because with sickle cell and childhood stroke, there are a lot of misdiagnoses that used to happen in the past. It's greatly reduced now, but at least that's a change that the guidelines will ensure doesn't happen. So like I said, my challenges was being a voice in a large group of professionals, not being able to communicate sometimes, but at the end of the day, it was, you know, an emotional process for me, because in my case, I didn't have to relive one stroke or two strokes. I had to relive the whole process my child went through, from the time he was 6 years old with the first stroke up to the time when he had the last stroke in 2013. And then on top, we've got sickle cell to contend with as well. So it wasn't just the stroke, it was the disabilities that occurred from the stroke plus the sickle cell. So it was very challenging for me, but the team understood and they supported me. I also have chronic illnesses myself, so there were times that I had to, you know, kind of think, do I go to this meeting or do I go for my hospital appointment? Also looking after my daughter, whether I should go for her school activity or whether I should go. But in the end, everything worked out for good. So at the end of the day, we did what gained the experience, and it's something that has really changed the scope of hemorrhagic stroke and stroke in children. So for me, the realization that 2 years of hard work has finally come to friction was something that I can put my hands up and say, yay, we did it. Thank you.
Fantastic. Thank you, Carol, for such an engaging talk, and a really interesting one as well. I find it so great that you were able to bring so many different stakeholders together to bring about this change for your patient community. It must have taken a lot of work, and thank you so much for sharing your story with us. So now we're going to be listening to Dr. Julie Valor-Tagara, who is the research officer at Ataxia UK, about her involvement in developing the medical guidelines for ataxia. Julie has been working with Ataxia UK's research department since November 2013. She gained a strong knowledge in neurosciences, and particularly neurological disorders, through her previous research studies on pain and later dementia at King's College London. She has developed a good understanding on the best practice for evaluation of research projects and their ongoing monitoring and support, dissemination of research information to people with ataxia and to researchers and healthcare professionals, which has also been an important part of her role. Julie has also contributed to the services provided to patients, such as the helpline, support groups, workshops and conferences. So thank you very much to Julie.
Lovely. So I hope you can hear me well and you can see my screen. Thank you very much, Find a Cure, for inviting me to take part in this webinar about medical guidelines. And thank you, Carol, for sharing such a personal experience in producing such guidelines. And I think you highlighted very well the patient's voice and the key role that patients and patient groups can play in producing such documents. So it was very interesting to listen to this talk, and I'm coming from a different angle in terms of how we updated and disseminated our medical guidelines. So I hope everybody who's listening to us today will enjoy the combination of the two talks, and I hope my talk will complete quite well what Carol already said. So here is an overview of my presentation today. So I'll be focusing on the updating process because it's not the first edition of our medical guidelines. So how we produced it and how we disseminated it and what our future plans are. So Obviously, working on a rare condition involves high stakes and challenges. I mean, we all know it just involves like several unmet medical needs. And we're also facing the problem of lack of knowledge and lack of understanding of how these rare conditions work, progress, and affect people's life on a daily basis. There is clearly a lack of awareness and a lack of resources available. I mean, for instance, when I talk about ataxia, the lack of awareness it's critical because we know less than 10% of the population in the UK has heard of ataxia or know what ataxia is. And obviously it goes hand in hand with lack of resources where you can find information, where you can find documentation to educate people, to educate the public, and also to educate healthcare professionals. So it's a big responsibility for patient groups like Ataxia UK to embrace these challenges that we are facing, and in hand with our patients we are supporting, and producing the medical guidelines, since we are the only one producing guidelines for the management of the ataxias in the UK. So these large guidelines includes list of recommendations for all sorts of interventions, from the diagnosis of ataxia, but also the patient referral pathways, several medical procedures, or interventions by allied healthcare professionals and palliative care. These guidelines aim to assist healthcare professionals when they care for patients with progressive ataxias. The guidelines indicate evidence-based when it exists and best practice. And I think overall they act as a useful resource for clinicians involved in managing ataxic patients. So this is how they look like. It's our third edition. They were produced last summer, July 2016. It's very important to say that they cover certain conditions, and I'm saying that because ataxia is a rare condition. It's in fact a group of rare neurological conditions, but it can be also a symptom experienced with other kind of conditions. So these guidelines are specifically covering hereditary ataxias, and among those there's different types, Friedreich's ataxia being the most common one, genetic form of ataxias, but you will also find guidelines for spinocerebellar ataxias and some episodic ataxias. It also covers idiopathic progressive ataxias, because many forms of cerebellar ataxias associated with neurodegeneration are actually of unknown cause. And we're also covering in these guidelines some specific neurological disorders where ataxia is experienced as a dominant symptom. So you have to, when you tackle a complex group of disorders such as the ataxias, you have to narrow down what you really want to cover and focus there. Ataxia UK is covering all type of ataxia apart from one, because there's two charities covering the AT form of ataxia. But we wanted to be focused on, with this document, about the ataxia as a condition or as a primary symptom. We've also produced a summary for GPs, which I'll explain later on in my talk. So how do you update such a large document? As Carol already explained, you need a guideline development group, which will be the group that facilitate the process and coordinate feedback, comments, and information sent by healthcare professionals taking part in this process of updating, producing these medical guidelines. Our guideline development group consisted of ataxia specialist neurologists, which are the consultant specifically working with patients with ataxia, and also representatives of Ataxia UK. I think it's important to say that we had a patient voice in these guideline development groups. The chair of Ataxia UK is also a person living with ataxia. And we had also a trustee of our charity who has a scientific background, but is also father of a patient. So patient voice as well as expert voice was very much present in this guideline development group. We also have a medical advisory panel that we work closely with. It's a group of 12 experts who they see patients with ataxia on a regular basis. Some of them run ataxia specialist centers. We have 3 of them in the UK, as well as specialist clinics for people living with ataxia. So these experts that we work with in terms of like medical advice and sharing the best practice, discussing new trials. We also ask for their input in terms of who to ask to update these sections of the medical guidelines. So they'll help us to identify specialists who will be likely to get involved and will dedicate time and will be committed to work on this new edition. Also, the word of mouth worked quite well from one healthcare professional you work closely with, introduced to other professionals that will be keen on working with us to produce this document. So we've been liaising really with around 30 experts to update and write the sections of the new edition. And it's important to say that as well as healthcare professionals contributed in this new edition, patients did also a great deal by suggesting new specific sections that were missing in the guidelines, such as there is a new section on diet and nutrition, or the whole section on palliative care didn't exist in the previous editions. We added it on because it's clearly there is a need from patients and carers and friends and relatives of people living with the condition to know better about palliative care and intervention that can be done when it's the end of life. So as I said, we worked with 32 specialist contributors who have clinical expertise in the field. They all spread out across the UK because we work across the whole country, and we've got a healthcare registry working with healthcare professionals in many different places in the UK. Their input in the guideline reflect the diverse clinical expertise in various aspects of how to diagnose ataxia and how to manage patients with ataxia. What they did, they reviewed the published literature in their respective sections, and they provided summaries on the best practice, including grading of evidence available for interventions using the Guideline International Network. And I will explain in a minute what I mean by level of evidence and grading for recommendation, because these are the two-stage process that we went through by identifying which kind of evidence is out there from literature and trying to convert this information into a grading system for each intervention that would just make the document easy to use by healthcare professionals who are new to the field of managing different symptoms experienced with ataxia. So evidence-based system that we use for these guidelines are scored from A to D, and then you've got the GPP. So A is systematic review of several placebo-controlled trials that were published. Then B, you've got 1 or 2 placebo-controlled trials. And as you go down the list, you have less and less evidence. So C is cohort studies, single arm studies, etc. D will be more based on descriptive studies, clinical experience. And GPP, it's very much based on the best practice, based on expert opinion or clinical experience. Throughout this process of developing the guidelines, the guideline development group reviewed all sections, produced recommendations with level of evidence, and discussed modification with contributors until the consensus was reached. And sometimes it took quite a while. Where no specific published data existed, then recommendations were based on data related to similar condition, for example, multiple sclerosis, and or expert consensus. So this table, which is on page 6 of our medical guidelines, is the grading system. So it is the evidence grading scheme that was used for these guidelines. So basically, how it works is you've got in the top end, the top part of the page, the level of evidence, which is a categorization of reference materials based on the Guideline International Network criteria from 1 to 4. We took these and basically we created a grading system for recommendation for our own guidelines based on this level of evidence, but very much adapted to the level of evidence that we had in our hands to list the recommendations. So you've got at the end of the document a large reference and bibliography about the different sections, as well as bibliography reference for this level of evidence and for the grading system that we use. So I hope it is quite clear that you've got very much this two-stage process, and each stage it's critical and was suggested by healthcare professionals working on sections and combined and agreed by the guideline development group. So when you go into the details of the document, this is how it looks like. So it's a list of recommendations for, as I said before, diagnosis, referrals, several medical interventions for very specific symptoms experienced with ataxia, as well as allied health professionals intervention. We've also added this palliative care section, and finally there is a section about research that lists key clinical trials and key medication have been tested in trials, as well as new avenues that should be investigated in research to hopefully develop new drugs and new interventions to treat better specific symptoms. These guidelines, they comprise 128 recommendations, and they're organized in these main 4 sections, which I've listed here, from diagnosis to palliative care. Overall, we had like 6 graded at level of B, which is right at towards the top of the grading system, 7 graded C, 10 graded D, and 105 graded at GPP. I wanted to highlight here the importance of to note the limitation when you set up a grading system, and we had to adopt one for the guidelines. But obviously there are some recommendations that do not lend themselves to this methodology. And if you flick through the document, there's been quite a few recommendations graded at GPP, so because of the lack of studies on the subject, meaning that it was impossible to categorize them at the higher grading category. To give you a brief example, it's very much the case for genetic testing. that now can be done through NHS referral, by sending blood to accredited labs for genetic testing. We've got facilities that can test more than 100 genes involved in different forms of ataxia. So significant progress has been made in this aspect of management of the ataxias. But although the intention of this recommendation can be strongly endorsed, it's appearing weak as it's graded by GPP. So in some cases, some recommendations may be self-evident, but it doesn't show up in the grading system, because the grading system is very much based on what is available online through literature data. So I thought it was an important point to highlight here, and I will comment about this point later on in my talk. So of course we've faced many challenges in updating these guidelines. I mean, of course, each time you update this, it gets larger. So it's very time consuming, it's a long process, and you've got a lot of information to combine in this document. Identifying specialists that will be keen in being involved, will have the knowledge and expertise, but also the time and the commitment and the will to be part of it, can be a great challenge. Coordinating the writing and the revision of all the sections. By that I mean incorporating all the comments from the medical guideline development group into one document that will be revised and proofread. It's also a big task. Obviously, you have to, Carol already mentioned that the admin side of things, arranging meetings and making yourself available to all these meetings can be challenging. And as I said before, there's a list of statements with good practice, based on good practice only, because of the lack of evidence in literature and references available. I think in producing these guidelines, we actually identified the urgent need to develop effective disease-modifying treatments. And given the large number of recommendations based on good practical points, emphasizing the need for further research to produce evidence for effective symptomatic therapies. So I think it's a great outcome through the challenges and things you identify in doing such process of updating, producing, or writing guidelines for the first time. It's identifying where are the needs for more research. And this is something we're going to take forward. In terms of the dissemination, which is a very big thing to do around producing the guidelines, obviously producing them, updating them, writing them, it's a big part of the work. But once you've got the document, it's critical what you're going to do with it. So we've put a detailed section on the medical guidelines on our website, and I will tell you a bit more about it in a minute of how we've done it. The dissemination to patients and healthcare professionals is very much done on demand. So patients take this document to their doctors, to their GPs or consultants or various healthcare professionals who they work with to make them aware of the documents and to help them in their interventions. We've got a primary care summary in a publisher called Guidelines, which I will talk about in a minute. We take these guidelines and raise awareness at events. So I've presented these guidelines already twice this year in various events at the Genetic Disorders UK Symposium and also in one of our Ataxia training day for medical professionals that we run across the country. They've also been published in scientific journals. We're working on 2 different journals at the moment, the Orphan Journal for Rare Disease and also Practical Neurology Journal, to get them published in the scientific journal world, if I may say, to make more researchers and professionals aware of it. And finally, but not the least, I think it's very important to target professional bodies of healthcare professionals that we work with, so such as the College of Occupational Therapists, or the Association of British Neurologists, or the Society of Physiotherapy, all the different professional bodies that are likely to be involved in any interventions to manage people living with the condition should be aware of such documents. But this work would not have been possible without working in collaboration. I think this is really the key slide of my talk today, my take-home message. You cannot do this work alone as a patient group because it's a big task, and also you need input from many different people to get you know, a good result and get it well disseminated. So it wouldn't have been possible without all the specialists that we worked closely with to update particular sections for a particular symptom. We worked also with Costello, with a medical consulting agency. We met Costello through our partnership with Find a Cure, and it was a fantastic collaboration because they make the document user-friendly online, and they facilitate the update and the dissemination with a live PDF. Basically, Costello offered to do the work on our website by putting all these guidelines in different sections. So it's very easy to use and to navigate on our website to go to a particular section, share this section with a carer, a patient, a friend, healthcare professional. From our end, it will be easier to update the next edition, because the idea is now to tackle the updating process section by section. So it should be less time consuming, and maybe we should be up to date quicker. So that was a fantastic job, and we're really, really pleased with Costello input there. And then we also got approached by a publisher called Guidelines, and they wanted to produce a summary for GP from our guidelines, making this large document into a summary of 3 pages only, available to their registry. And after 3 months that it was online on their website, we got the PDF. Then we can use the PDF to share to our own registry and to patients as well. So we did produce a GP summary for the 2nd edition, but that was a hard copy, that was a document. We didn't really use it online, whereas now we've got this PDF that is also much easier to share, to raise awareness, and to reach more people. So I think it really is great to see from that work collaborations being set up. Because working together we are stronger, and I think this is what we need to do in a rare disease field, to raise awareness quicker and to progress faster towards better medical care, and hopefully also more effective treatments available to patients. We've also produced this very nice leaflet. It's an A5 leaflet, very easy to give out at events, to send in a welcoming pack, information pack, or medical pack when we got a new registration to our charity. It is to make people aware of the guidelines without giving this large document systematically. On this leaflet, there's a bit about what are these conditions and what can you do, where you can find the medical guidelines, how can you make a referral, and also making people aware about the specific ataxia centers that we have across the UK. So we've got 3 in Newcastle, Sheffield, and London. They were our initiative, and we promoted the opening of these centers, working in collaboration with a neurologist on site with expertise and interest in the ataxias. So after promoting the opening and funding Ataxia Nurse there. This is now a service that is available through NHS. So people can be referred to these centers by their GPs or local neurologists. So I think it is very important to make such leaflets and such materials to help with the dissemination, because obviously hard copies, when it's a large document, cost money to produce, cost money to print, cost money to send out. So having a little material like that, such a leaflet, it's very useful as well. So I'm coming towards the end of my talk, which I hope you have enjoyed so far. Here are some plans for us following the production of our guidelines. Well, first of all, I think it's very important for us to know the impact of the guidelines we're producing. So it's very key to get feedback from the users. First, from the healthcare professionals. So when we give out such document at our Ataxia medical seminar that we run twice this week, such event, one in Belfast and one in Exeter, which are aimed to educate healthcare professionals and raise awareness and making them aware of medical guidelines, about last research progress and this different interventions and therapies that are available for a patient living with ataxia. So when we create guidelines, we aim they are a useful tool for healthcare professionals who care for patients with progressive ataxias. So obviously we are very keen on hearing any comments about the recommendation listed in such documents. So we are thinking about building a survey for healthcare professionals to know the impact of these guidelines, get their feedback about the list of recommendations, but also invite them, in fact, to tell us if there is any interventions or any new evidence, new publication that we may have missed, we're not aware of it, that we should be adding in the guidelines. So it's very key to engage as many healthcare professionals as possible to collect information, collect data or new literature, and improve each sections of the guidelines. Obviously, we are very interested in hearing from our members and people living with the condition. So we ran a survey to our members recently. That 426 people with progressive ataxia answered. To identify what they perceived to be the most pressing medical needs. So then we know what are the symptoms that impact the most their life. Interestingly, impairments in balance, coordination, and speech were highlighted as symptoms with greatest impact, which is not a surprise because these symptoms are the key symptoms experienced with ataxia. But also there was fatigue, there was mental health issues that were scored quite high by members. So it is interesting for us to know that we are thinking of including a fatigue section in the next edition, having a whole section on how to manage fatigue, maybe extend our section on mental health issues. So it's key for us how to get feedback, how to improve our medical guidelines, what to put in our next edition. So we are aiming to update this section individually and try to make the process easier and less time consuming by starting on working on new sections already and engaging with healthcare professionals who will be keen on working on some of those. And also, maybe the next edition should be NICE approved. It will be a totally new process for us. Because NICE doesn't produce any guidelines for the ataxias or any similar conditions that we can use. And it's very important now, our guidelines are quite established, that we should get them NICE approved. And by that I mean they should be following the guidelines and the format of NICE. So it will be a different document, it will follow different guidelines and recommendation style. So we are also already working on that for the next edition. And I mean, as I said before, but I think it's very important for you to understand that the production of these guidelines has really revealed, to us, a considerable overlap between what are seen to be areas requiring further research by professionals and symptoms requiring most amelioration identified by patients. So for us, it would be information used for our the new edition of our research strategy, the new edition of our medical guidelines. More research is needed to identify novel therapies and interventions to tackle these very specific symptoms and to produce new therapies and treatment that will be more effective to our patients. This is it. So I thank you very much for listening, and any questions will be more than welcome. And I hope you enjoyed my talk. Thank you.
Great, thank you so much, Julie, for a really useful and interesting presentation. It was really interesting to get your perspective as a researcher involved in a patient group on how you worked with different groups to bring about the redevelopment of the guidelines, and yeah, some really useful points there. Thank you so much. So we're now coming on to the question section of the webinar. Just a reminder for everyone, please, to send in your questions. All you have to do is type them into the question box in the control panel, and I will read them out to the relevant speakers. So yeah, please do keep them coming in. No question is too stupid. Just send them in, and we'll answer them. And it's a good opportunity for you to hear from some very experienced speakers. So first of all, our first question for both speakers is, what have you found has been the NHS's position on rare disease guidelines? Are they encouraging of patient group engagement in producing the guidelines? So maybe if we ask Julie first.
Yeah, thank you for this question. It's a very interesting one. To be quite honest, I'm not aware of any engagement or input or interaction with NHS through the production of our medical guidelines. I think it's very much a process that we've done ourselves with our resources and with our network of healthcare professionals and members and contributors. As I said, we are starting to connect with NICE for the next step of the guidelines. And obviously all the contributors and experts we worked with are working in an NHS, and most of the intervention listed in the guidelines are accessible through NHS prescriptions or referrals. But I couldn't say if NHS as an organization is being involved closely with the production of these guidelines.
Effective.
Okay. Oh.
Yeah.
Oh, sorry, Carol. I'm over to you. Sorry.
Okay. From my perspective, I'm not sure about the NHS itself being involved in the guidelines, although there were NHS staff involved. I do know that it has been it's been accredited by NICE, and there was also talk about dissemination of the guidelines to different trusts to ensure that it's actually used. But that's as far as I know so far about the NHS involvement.
Okay, great. Thank you. So another question I've had is that when you're involving such a large group of stakeholders and collaborators, How do you manage all the voices and opinions and make sure that everybody's heard? And were there any like conflicts that came up, and how did you manage those? Maybe Carol first.
Yeah. My experience, in my experience, I didn't come, um, I didn't get any conflict from everyone or from anyone. Basically, at the beginning, introductions were made. As people joined the team, you get reintroduced. We had time for networking where we could talk with different people that were part of the team. So it kind of it didn't feel like a very formal atmosphere, but it was more informal, and I think that's what helped everyone to kind of know the background of each person and what they had to contribute and be able to come together as one. So that was my experience.
Yes, if I can add a bit of our experience regarding finding a consensus. I think this is quite obvious when you work on a rare condition with very specific symptoms that most of the sections were written or updated by one expert, because you wouldn't come across many experts in the field of ataxias working on a specific symptom, if you see what I mean. Or if you had several, we had sections that were updated by two professionals. I think it's quite easy to find a consensus between two professionals. Then it was also discussed by the guideline development group, where two neurologists were attending meetings and finalizing comments and implementing updates. But as I said, for many sections, it was based on what level of evidence is available out there, plus the best practice and expertise from a particular professional. So although it can be tedious in terms of amount of information that you need to incorporate into the document and agree on a consensus for each of those, I don't think that was a challenge to agree on those recommendations, really.
Okay, great. Thank you for sharing that. So another question that's come in specifically for Carol is, you said that you had some training to sort of before you participated in the process. What did that involve, and what can you recommend from that sort of training process to other patient groups who might be looking to train other parent experts?
Okay, so the training was very important because it helped all of us to kind of be on the same level in terms of we parents had different experiences. So mine was mainly sickle cell induced stroke, which is a different, well, the sickle cell caused the stroke. So another parent, their daughter had moya moya, and also the ages at which the strokes happened were different. So it was to get three of us on the same page to basically know what each other's experience was and how we went through the medical journey with our children and what was involved. So we kind of gelled together, and we felt that, you know, we had different aspects to cover. So initially, the Royal College of Pediatrics got us together, and we talked about this. So from there, they explained to us through several. It's at different stages. The training was at different stages. So initially it was about feeling welcome, feeling able to contribute, feeling relaxed, feeling also to open up, because also in terms of opening up, you're going through experiences, some of which you don't want to go through again, and being able to have some kind of counseling in in place for you should you begin to waver. Also, that was important because there are things you remember and you'll cry, but knowing that you have someone to support you and that you're in the right place, it makes a whole load of a lot of difference. So also, when it came to the literature review, we all sat down with someone from the Royal College, and they went through it several times till we understood. There was always someone from the Stroke Association sitting next to us who would explain different terminologies that are being used, and would actually put their hand up, and people would actually stop. And I felt it felt a bit strange because it felt like you were disrupting the meeting, but in actual fact, everyone really wanted to know what we had to say. So being able to feel relaxed is important for patients to be able to open up with their experiences and to be able to engage with them at a level and support them through advice, counseling, being at the end of the phone if they have any questions they need to ask, or if there's something they remembered when they got home, they could actually phone up and say, oh, I thought about this, this and that. Also being able to email, just to make sure that there's always that constant contact through the whole process. I found that very important. So even if they were in hospital or they weren't able to come for some reason, there was still that email keeping you in the loop, which is very important as well. And through there, you're not just dealing with in our case, the parents, but you're also dealing with the young people that are involved, getting them to come to some of the focus groups that we had. There were young people there, and they felt welcomed, and they felt that their experience, they were made to feel that their experience is key, which it was actually in developing the childhood stroke guidelines.
Great. I'm
Yeah.
really glad. Oh, sorry. I'm really glad that it was such a sort of welcoming environment for you. It sounds like that was a really important part of the process for you.
Yes, it
Um,
was.
yeah, oh, great. So we have another question just specifically for Julie. This is if we want to start, so this is from another patient group called ncsaware.org. If we want to start putting together guidelines for our condition and to evaluate research and treatment, who do we approach to help us with that? Would we need a medical researcher, or is there another job role that is more appropriate?
Yes, that's a good question. A medical professional who is active in research, I would say, would be a good start if you know such person in your network. Because obviously you can work with healthcare professionals, clinicians, on different sections of your medical guidelines, and is absolutely fine, and you need their input. But if you wanted to add this the aspect of research, then a clinician who is also a researcher would be actually ticking two boxes in one, if you see what I mean. I mean, from our own experience, the clinicians who are working in our Ataxia centers, which we believe are the centers where best practice and best care management of the ataxias are done. the requirement for the clinicians to work in such center is also to be active in research, because we truly believe that if you want to progress in the care, in treatments and interventions and therapies, anything that will be effective to manage better a particular condition, specific symptoms. I think your approach needs to be based on best clinical practice, but also on research. And by doing research, you are producing and providing more level of evidence for the best clinical practice you want to implement. So that will be my advice. But having said that, you will probably benefit from working with clinicians, experts in your field who are purely doing a clinical work, and also experts who are active in research. I think having input from medical professionals having various activities will probably give you a combination of information useful for your guidelines. So I hope this is helpful, what I'm saying.
Great, thank you, Julie. So I've got another question on how can you assess how much guidelines are used and implemented by clinicians? Julie, would you like to go first?
Yeah, sure. Well, it's a very good question, and I don't think we've got a full answer to that yet. I mean, as I said, as part of our plans, we are aiming to run a survey across the registry of healthcare professionals that we have, which I think we've got 370 healthcare professionals on that registry at the moment. So I wouldn't have this information yet, but what I can say is when we run this Ataxia medical seminar, which are specifically designed for healthcare professionals to engage with communities locally to raise awareness and educate professionals working in a particular area of the country about the ataxias, what are they and how they can be managed better. Then in a feedback form of professionals attending such events, we have information about how much impact such seminar can have on their knowledge, on their practice. The fact that the last seminar we did in Exeter, we brought I think 1 copy of the guideline per delegate, and everybody took a copy. Everybody was really happy to get a hard copy of the medical guidelines. We've been told that healthcare professionals like to use electronic documents, so having medical guidelines on our website in a PDF user-friendly format was key for us. And thanks to Costello, we've got that now available. But I think the hard copy is necessary, and that means this copy exists and in the clinic, can be, consulted by people visiting the clinic. But in terms of impact, we do hope it actually changes the practice and the intervention that people and healthcare professionals are using to treat patients. But I would say after running the survey we're aiming to do, hopefully we'll have many healthcare professionals participating in such survey. I would have a full answer to that question there. It's a bit early stage to know that yet, I think, particularly for this new edition.
Okay, great. Thank you, Julia. That's a really useful insight. Carol, do you have anything to add?
Just what I want to add is that we had, in terms of sickle cell and the guidelines being used, we had hematologists on board in the team. So I'm sure that they have taken the guidelines and they're working with it. I think also that it's early days, and also that it was only launched in May, on May the 24th. So it's early days, but I'm sure the Royal College and the Stroke Association will be looking at how the guidelines are being used and which clinicians and which areas are actually using the guidelines.
Okay, great, thank you. So I'm just going to wait for a few more questions to come in, and if anybody has anything that they do want to ask, and you can't find the question box, if you click the little orange arrow in the little toolbar, then that will open out a wider screen, and you can ask a question in the question box. So do keep them coming in. While you have a minute to type them, I'll just quickly introduce a couple of things that we've got going on at FindCure in the next couple of months. So our next event is the Cambridge Rare Disease Showcase, which will be taking place in the evening on Thursday 24th of August in central Cambridge. The event it hopes to sort of build and bring together the rare disease community in Cambridge, and everyone is welcome: patients, patient groups, clinicians, industry, researchers, etc. So we would love to see you there. And same goes for our Newcastle Rare Disease Showcase, which was actually only announced yesterday, so it's very early days, but that's taking place on Tuesday 31st of October. It's a full day event from 10 till 4:30 at Centre of Light for Newcastle, and the aim again is to build the community of all the rare disease stakeholders in the northeast and eastern area. We do also have a workshop taking place on Friday the 8th of September on working with industry. Unfortunately, that workshop is full, but we do have a waiting list, so if anybody is interested in coming along, please do still sign up, and we'll put you on the waiting list and let you know nearer the time if we've been able to allocate you a space or not. So any of those events, we'd love to see you there, and get in touch if you have any questions about them. So let me just check if we have any more questions. So we have another one from the same MCS Aware group. When you have your guidelines, who would you approach in the UK to get the condition officially recognised? Our condition is recognised around the world, but not yet in the UK. Any thoughts on that? Maybe Julie first?
Yes, thank you. Wow, that's a very it's a very interesting question. I'm not sure I've got the answer to this, to get a condition registered. I mean, I would say approaching the NHS could be a first step if it's not recognized here. I mean, I assume the question is related to a rare condition. So the other way to maybe get more influence and power in getting that recognized would be to contact Rare Disease UK and see with them what can be done about recognizing the condition you're working on, because obviously it's a key step for you to move forwards. So maybe umbrella organizations of that kind will be good, specifically if it's a rare condition. I would say Rare Disease UK. If it's a genetic condition, then the Genetic Alliance UK could be a good one to contact as well. National Voices is also a good organization who represent patients and patient voice to the NHS and to the government. So any contact with those organizations will be probably very useful, I think. I hope it's useful.
Great, thank you, Julie. Do you have any thoughts, Carol?
I think Julie's done the question justice.
Okay, great, cool, thank you. So another question we've had in is, when dealing with rare conditions and or undiagnosed conditions, there is the problem that they often require more time and resources than other better known conditions. How should clinicians address this issue? Maybe Carol first?
Could you say that question again, please?
Sure. So I think it's about how you can try to get clinicians and doctors to maybe read your guidelines, and when they're so sort of like when they've got so many demands on their time, how do you work with them to make sure that they do read and take note of your guidelines? I think is what the question's getting at.
Okay, well, for me, it's a bit difficult to come in from a patient perspective because already many conditions are already known, and especially when it's a rare condition, it's a bit difficult to find the right physician to actually speak to about it. I would go back to, especially when my son had the first stroke he had. I I knew that it could cause stroke, but I didn't know what the warning signs were, nor did I know, the symptoms. So he had been having symptoms before, but I didn't put it down to a stroke till he actually had the main paralysis that I could see that, yes, this was a stroke. But in terms of speaking to physicians, I was able to get across to them that I have concerns about what is happening because there was a build-up. Unfortunately, I wasn't listened to. But in hindsight, I think that it's about being more proactive and being more, able to raise your voice so that they can actually see that there's a concern. And I also think that sometimes it's best to get a second opinion if you're not sure, because I believe that mother's instinct is quite strong. So when you're not sure, you should at least seek a second opinion. I think I'm not sure if that answers the question.
No, no, I think that was some really good thoughts there about how it's important for, on the kind of patient side to drive forward that kind of recognition, so that clinicians can see the issue and hopefully give it the time that it deserves. Julie,
Yeah.
do you have any thoughts about it?
Yes, I think it's a very important question, and this is going back to how can we raise more awareness about rare condition and about resources that are available to treat people living with a rare condition in the best way possible. It's very tricky, I think. Making sure they read your document, I don't even know if we have power there to do that. I would be more inclined to say making sure we are present, making sure we make people aware that we exist as an organization, that we exist in terms of like providing support, resources, and information to the public, to the carers, and to the healthcare professionals. I mean, I keep on going back to this Ataxia medical seminar, but I think because they're key. Once again, the last one we did in Exeter, and some feedback of people attending, they say, that was a really interesting seminar, and I can't wait to tell all about it to my colleagues and my clinical team. Well, that's what we want. Exactly that. We want to engage more people, but we want people to do that for us as well, because our resources are limited as well. So how do you raise more awareness when you ask members, carers, relative friends, healthcare professionals, our contributors and collaborators to do their bit about saying the guidelines on our website, having leaflets being put in hospitals and various specialist clinics and centers, having this summary for GP, I think this is key to have a small document. When we talk about guidelines, it's usually a very large document that puts people off to read that much. But what if you have the single leaflet that I showed you, or the summary for GPs, which is 3 pages long? It's very quickly read. And then if people want to find out more, and hopefully they would, then they can go to the big document. So it's using all the channels, really, as well as the professional bodies, and making sure people are aware that information is there if they need. Through our helpline, I get a lot of inquiries from professionals for all sorts, surgery procedure on a patient with ataxia, helping for this or that symptom that they never cross before. Yet is a new professional I'm engaging with, and I'm sending the information out, and I tell them about the registry, and hopefully they will spread the word themselves. So it's about the strategy, I think, and hopefully, yes, ultimately, when they need, they know the information is there and they can read the document. So yes, I think that will be my answer.
Okay, great. Thank you so much, Julie. I think you're right in that it's kind of almost like a kind of virtuous circle where you need to just get the ball rolling with sort of raising the awareness, and then that will drive more awareness and kind of word of mouth and everything. So great, thank you. So we've actually reached the end of the webinar. Sorry that it's run over by a few minutes. I hope it's not causing anyone any inconvenience. I'd just like to say a huge thank you to both of our speakers for coming today and sharing their thoughts and their experience with us on this topic. They've been so helpful, and I'm sure everyone who attended has found it really useful too. Recordings of the webinar will be sent out hopefully by tomorrow, along with a feedback form, which would be really grateful if all attendees could fill in. And if you do have any questions following the webinar, please do get in touch. My email address is there, and I can forward them on to the relevant speakers, or if it's something that I can answer, I'll get back to you. Yeah, so thank you very much for coming along, and I hope you all have a lovely afternoon. Goodbye.